Hi, I'm Jenny Johnson, Shoemaker Proficiency Partner, CIRS coach, and CIRS consultant. We're going to be talking about what CIRS is and what CIRS isn't, and how it comes to be in certain populations. So CIRS, or Chronic Inflammatory Response Syndrome, CIRS, is a term that was coined by Dr. Richie Shoemaker in the mid-1990s. It is also known as biotoxin illness, and it is a multi-system, multi-symptom illness that is frequently misdiagnosed or considered medically unexplained by practitioners who have not been trained in the diagnosis and treatment of this condition. So what does CIRS look and feel like? Here is a chart of the most common and research-based symptoms that are associated with CIRS. I'm going to read through these in case you're listening to me. We have fatigue, weakness, decreased assimilation of knowledge, aches, headache, light sensitivity, memory impairment, decreased word finding, difficulty concentrating, joint pain, morning stiffness, cramps, unusual skin sensitivity, tingling, shortness of breath, sinus congestion, cough, excessive thirst, confusion, appetite swings, difficulty regulating body temperature, red eyes, blurry vision, night sweats, mood swings, ice pick pain, abdominal pain, diarrhea, numbness, tearing, disorientation, metallic taste, static shocks, and vertigo. This is not an exhaustive list of all of the symptoms that may occur when an individual is diagnosed with CIRS. But again, these are the most common. And if you want to use this as a screening tool, if you have symptoms in at least 6 different colored boxes here, we call those clusters. And gosh, if you have at least 8 different clusters, that is highly correlative with CIRS. I would say that if you have 6, it is worth it to go on to the next stage of screening or even diagnosis. For children, for individuals less than the age of 12, that number is a little bit less. We do see fewer symptoms in kiddos, but symptom clusters of 4 or more would be suggestive of additional workup. There are other symptoms that are associated with CIRS and quite common, and I will include those here: anxiety, depression, suicidal ideation, intestinal permeability or leaky gut, and dysmenorrhea, which is painful or irregular periods for women. I see those quite a bit. And then in kiddos who are less than 12, we see a slightly different presentation, fewer clusters, and usually the initial symptoms are headache and stomach ache. And these can be so easily dismissed or assumed to be due to other things. Headaches and stomach aches, especially if they are persistent or frequent, can be a key factor in CIRS for kiddos. We also see anxiety. We see PANS and PANDAS. We see autism. We see OCD, aggression, opposition, and defiance. We also see bedwetting, particularly beyond the age that we might expect that, such as maybe 5 or 6 years old, due to an inability to hold on to our water, which is one of the classic symptoms with CIRS. So this may be a classic presentation, is having symptoms across the board in multiple different boxes here representing different systems. Here are some of the common misdiagnoses for CIRS that so many patients get when they go to their PCP or even start seeing specialists trying to explain how they feel. They are often given a diagnosis that may put a label on some of their symptoms, yet without getting to the root cause, or might even get to maybe an incorrect label. Some of those labels we see often are fibromyalgia, chronic fatigue syndrome, multiple sclerosis, depression, stress or even anxiety, allergies, PTSD, somatization, irritable bowel syndrome, and attention deficit disorder. You will see a lot of these are actually symptoms and not explanations of an illness. And CIRS can be the umbrella that holds all of these symptoms together. So let's talk about how one gets CIRS. How does this happen? These are some steps that we're going to go through as an overview first, and then we're going to go through each of these steps or layers in more depth to come. So typically, not always, but typically CIRS begins with genetic susceptibility. And about 24% of the population, potentially more, does have a genetic susceptibility to developing CIRS. And what that means is they have an inability to create antibodies to biotoxins. So next comes a priming event that actually upregulates or turns on that genetic susceptibility. So we may be born with a certain genetic profile, and it is basically in the off position or down regulated. A priming event turns that gene on, and we now becomes more susceptible. Then all it takes is an exposure to biotoxins for the innate immune system to start creating inflammation in response to these foreign invaders, the mycotoxins that we are breathing in. Our body senses that these are problematic and need to be killed. The problem is these toxins are not alive. They're not the actual mold spores that are problematic. It's the toxins that are produced by microbes in our environment. And they are not alive, cannot be killed, but they are detected as foreign invaders. And so our body starts to mount an inflammatory response against those foreign invaders. Our adaptive immune system, however, the part that's supposed to make antibodies and usher these agents out of our body, is unable to do so effectively, and we cannot clear them properly. So instead of being cleared through the stool, biotoxins cross the cell membranes of different tissue types and can cause chronic inflammation throughout the whole body. So let's go through these layers in a little bit more detail here in case that's helpful for you. We'll start with genetic susceptibility. According to Dr. Richie Shoemaker's preliminary research, roughly 24% of the population has a genetic susceptibility to CIRS. About 2% of the population actually has multiple susceptibility. These can be known as dreaded haplotypes. I don't love that term, but if you've been given the haplotype name 11.352b or 12.352b, 4.353, or 14.552b, that's how we read these, then that means you have a susceptibility to developing CIRS, not just from mold exposure, but also potentially to bacteria exposure, to a tick bite, such as or a microbe within a tick bite, such as Lyme disease, or even other biotoxins associated with algae or brown recluse spider bites, aquatic dinoflagellates. We'll be getting into that. And roughly about 2% of the population has that level of susceptibility. These other types of susceptibility to specific biotoxins, such as mold or Lyme or dinoflagellates, and on down the line, can be depicted here by these haplotypes. And when I mean haplotype, we get one from each of our parents, and if we have either one from either parent that is in this either multiple susceptible or maybe mold or chronic Lyme is susceptible to one of these biotoxins, then we can more easily develop CIRS than someone who has low mold, no mold, or benign HLA-DR types. So this is a test that your physician can order for you. It's a lab test through LabCorp called the HLA-DR test. It can also be ordered direct to patients on lifeextension.com. And this is a cheek swab kit that you can order, and it's sent to your house, and you can do a cheek swab, send it in, and then you will get the results by mail. So you can find out if you do have the genetic susceptibility for CIRS. So then what primes this gene? If we're born with it likely in the off position and something turns it on in the course of our lifetime, what might that priming event be? What we know the most about is inflammatory illnesses and their potential to prime our genes. So inflammatory illnesses might be COVID. It might be Lyme disease. It might be Epstein-Barr or another illness that has an inflammatory component to it. that can be enough to turn on our HLA-DR that is susceptible to CIRS. It is thought that a significant toxic exposure could be enough to do the same. This might be a significant exposure to water damaged buildings, to the toxic soup, the mold, the bacteria, the VOCs that are present in water damaged buildings could be enough to upregulate one's gene. It's not known yet whether significant chemical exposures, heavy metal exposures, EMF exposures may be enough to prime a gene, but it certainly makes sense that it could be. Physical stress and trauma, such as pregnancy, surgery, car accidents, abuse, or even poor lifestyle, such as diet and sleep, may be enough to upregulate an HLA-DR. And then last but not least, emotional stress or trauma, such as a divorce, a loss of a job, a loss of a loved one. Events such as these may also be enough to prime one's genetic susceptibility. So then when you have the gene, it is primed into the on position. All that needs to happen is exposure to biotoxins for the next steps to ensue. 80% of individuals with CIRS have water damaged buildings as their primary exposure event. And it is not just mold, but it truly is a toxic soup of fungi, bacteria, the volatile organic compounds that microbes can emit directly, and the VOCs that can be emitted from water damaged building materials as they are being degraded. And then even just the cell wall fragments, dead mold, old mold, crumbs of mold from structures of the hyphae or the cell walls, and bacteria as well. And byproducts that are produced by mold and bacteria can all be part of this toxic soup that we call water damage building exposure, rather than just mold or bacteria. We also have microbes that can be induced through the skin through a tick bite, and this might be Borrelia, Babesia, Bartonella, Anaplasma, or Ehrlichia. Most people call this Lyme disease and co-infections, and they too can induce a biotoxin exposure that leads to CIRS. Blue-green algae. This is another potential source of exposure for folks, especially who have the multi-susceptible genetics. Aquatic dinoflagellates. These can be acquired potentially from swimming with dinoflagellates in the ocean, but certainly from ingesting fish who have ingested dinoflagellates. So if you go on vacation and you want to eat some parrotfish or other reef fish, or you love grouper, other predator fish, you may be at a higher risk for exposure to biotoxins because of what those fish eat. The dinoflagellates are biotoxin producers. And then lastly, brown recluse spider bite toxins. So this also is induced through a bite of an insect, just like the tick-borne microbes. But for some individuals, there's an acute maybe infection from the spider bite, but then it turns into a chronic, long-term, multi-systemic illness that is CIRS due to a brown recluse spider bite. So let's talk about what's supposed to happen in the immune system if, say, you're in the 76% of the population that responds normally to a biotoxin exposure. So there would be an exposure for this person with a normal immune response. Say they walk into a building that is water damaged and maybe has some elevations of microbes. Those biotoxins that are inhaled would be recognized as foreign by their immune system, bound by their adaptive immune system, and then ushered naturally out of the body through the stool. So somebody who has, does not have a faulty immune response might not feel great if they have this exposure. They might have some short-term acute symptoms, but they're not going to have the long-term multi-systemic issues that somebody with a faulty immune response is going to have because these toxins are ushered out of the body so quickly. So let's talk about what happens with a faulty immune response. So we have a genetically susceptible individual who has been primed and they are exposed to biotoxins. Next, those biotoxins are not recognized as foreign by their adaptive immune system, so they are not excreted. Instead, those biotoxins move between cells, causing damage to various systems. The innate immune system of the individual then responds by creating systemic inflammation. This is the part of our immune system that actually does work properly. It just doesn't turn off, but it senses that there's something foreign there and it's trying to kill or put out that fire, actually create a fire to kill these invaders. And that fire is ongoing because the invader persists. The toxins can't be killed. They are not alive to begin with. And since they are not being excreted normally, the toxins persist in our body, and so this inflammatory response persists as well. And that systemic inflammation can take place in all types of body tissues and different systems in our body. So we have our GI system, we have our musculoskeletal system, our neurological system, all parts of our body can be feeling this inflammatory response. This is a wonderful pictorial depiction of what I just explained called the biotoxin pathway. We'll go through it pretty briefly here, but you'll see in the top left this large blue arrow showing toxins coming into the body, either through the air, through breathing, through ingestion of certain foods or water that may have microbes, or through a bug bite. And this arrow down here is showing how these toxins are removed from the body in people who have a normally functioning immune system and maybe are not genetically primed to develop CIRS. Now, these two arrows here show what happens in the HLA susceptible or genetically susceptible individual who has been primed and has a faulty immune response. We'll talk about the inflammation component first. So what happens is we have this increase of inflammatory cytokines such as C4a, transforming growth factor beta 1 or TGF beta 1. MMP9 is another one that maybe sounds familiar to you. These are signs that we have systemic inflammation pumping out through our body, which causes a whole bunch of downline symptoms that you can see over here. Another pathway of dysfunction that occurs in the genetically susceptible folks who've been primed and then exposed to biotoxins is considered the hypothalamic disruption, or HPA axis disruption. And what happens along this pathway, the main thing that happens is a drop in a hormone called melanocyte stimulating hormone. And this is one of the signs, actually one of the first signs that our gene, our HLA-DR genetic susceptibility, has been upregulated or primed. So when our MSH has dropped below the bottom threshold of 35, that's a sign that we are likely at the beginning or somewhere along this pathway of immune susceptibility to biotoxin exposures and maybe even full-on CIRS. So what happens when our MSH drops below 35? Well, you can see all of these different arrows here pointing to the downline impacts. We'll go through these briefly, but when we have reduced MSH, we have a disrupted production of melatonin. And so our circadian rhythm becomes dysfunctional. We start not sleeping very well. Excuse me. A chronic pain. We have a lowered pain threshold when our MSH drops. We also have perpetual leaky gut. Toxins can directly cause leaky gut or gut permeability, but when we have reduced melanocyte stimulating hormone, this is another indirect cause or perpetuator of gut or of intestinal permeability. So when doctors say that everything starts in the gut and we have to start with fixing the gut, that is true, but sometimes there are issues that are even deep to the gut and need to be addressed first, such as the presence of toxins or a decreased level of melanocyte stimulating hormone. That's going to make gut healing quite difficult. Prolonged illness. So we can have just an impaired immune response to infections and things like that, and have a more difficult time recovering from illnesses, diseases, and infections. Changes in our cortisol and ACTH levels. This is our androgen, or I'm sorry, our adrenal system. And so what used to be considered adrenal fatigue is very common in CIRS patients when our cortisol actually drops so low that we are unable to mount the proper physiological response to the stress that we are feeling. And this can be one of the underlying causes of the fatigue that we experience, that low level of cortisol. Some people have super high cortisol. So either too high cortisol, maybe a dysregulated stress response by pumping out too much cortisol, or not having enough cortisol can be signs of CIRS. Having disrupted sex hormones, these are called androgens, can be another side effect of having reduced MSH. So this is testosterone, it can be estrogen, and I do recommend, if you have disturbances or imbalances in your sex hormones, to address these in concert with your Shoemaker protocol treatment with your CIRS doctor. If you try to address those separately from your CIRS treatment, you might find that you're doing things perhaps at the wrong time, and they can actually have there can be undesirable side effects of maybe supplementing testosterone or something at the wrong time in your treatment. Reduced antidiuretic hormone. This takes us back to that bedwetting for kids, but even in adults, what this presents as is persistent thirst and then constant going to the bathroom. It's similar to what happens if we have too much caffeine or alcohol, where we can't hold on to our water. It just comes right out of us. And when our MSH is low, it tends to suppress our antidiuretic hormone. So our body does not hold on to water, and we can become functionally dehydrated. So it's important to work with your practitioner on maintaining a proper osmolality, maintaining a good electrolyte balance, and not getting dehydrated. And then last but not least, MARCoNS, multiple antibiotic resistant coag negative staphylococcus infection. We'll be talking a little bit more about this in another video, but this is an opportunistic bacterial infection, not a fungal infection, that is common in our nasal passages or dental cavitations when we have CIRS. Again, it is opportunistic, and when our immune system is a little bit dysfunctional, it can come in and take residence and it really put its thumb actually on our MSH production and further suppress it. And so there can be this positive feedback loop. When our MSH is low, we are more susceptible to developing this opportunistic infection, MARCoNS. But once we have MARCoNS, it tends to keep our MSH low. And so this can be a perpetuator and a significant contributor to the CIRS experience, having this opportunistic infection. So your doctor will likely test you for MARCoNS and then treat if you are positive, as that can be a big part of the protocol. Thank you so much, and I hope you will join me for the next talk on how CIRS is diagnosed, and then another additional talk on what to expect with CIRS treatment.